Great. Well, it's an honor to host this episode of Scoliosis Dialogues, the official SRS podcast. My name is Byron Stephens. I'm Associate Professor of Orthopedic Surgery and Residency Program Director at Vanderbilt University in Nashville, Tennessee. And tonight, our guest is Dr. Peter Passias, orthopedic spine surgeon at Duke University. And Dr. Passias, I think anybody who's attended an SRS meeting in the last 10 years is certainly familiar with your work, but I think it would be advantageous for maybe some members of our audience to hear you tell us about yourself, your background, as well as your clinical and research interest in your current practice.
Yeah, first of all, thank you so much for inviting me. And it's an equal honor to participate in this with you, Dr. Stephens. I think these are really great for our audience to dive deeper into these manuscripts we put so much work into. So I am, as you mentioned, I'm Associate Chief of Spine, Orthopedic and Neurosurgery at Duke. I'm new to Duke. I've only been here for about 6 months. And my previous 14 years of practice, I was associate professor at NYU in New York. And my educational background, other than my the typical medical background, prior to that was based in mechanical engineering. And I think that's one thing I like to mention. And then following my training, I did several fellowships, most of which were deformity based, both pediatric and adult in the Boston and New York area. And my research interest really has been from the get-go, even prior to going into medicine, with basic science related research. And since going into medicine, most of my research has been clinical based, with several translational pieces as well. But the predominance of my research has been with adult spinal deformity, realignment outcomes, and really methods to improve how we treat these patients.
Great. And of course, the paper we're talking about today is a recent paper of yours titled Contemporary Utilization of Three-Column Osteotomy Techniques in a Prospective Complex Spinal Deformity Multicenter Database, Implications on Full Body Alignment and Perioperative Course. This is a topic that I love talking about. I'm super excited to hear your thoughts and takeaways from this project. I think a little bit of background would also be perhaps useful for the audience. Do you want to sort of tell us kind of the story behind this project, sort of how the idea for this project was born and where this started?
Yeah, absolutely. So this is, first of all, I'd like to thank the ISSG. This is really a collaborative effort to construct such a work. And, this was an offshoot of another study, kind of the continuation of a study that we had performed looking at rigid deformities and non-rigid deformities, and amongst which in our original data set were three-column osteotomies being utilized. And this was a little bit of a different data set in that it didn't represent entirely complex deformity. It was our initial data set that was both operative and non-operative treatment of spinal deformities, and it had less stringent criteria for alignment in terms of inclusion, and there was really no stipulation of the intention to treat. So the patients involved in that were a little bit more of a mixed bag. And fast forward to the current study, this was using our referred to as CADS database, complex adult spinal deformity data set, and really has much more strict criteria of who gets enrolled in these in this registry. The sites are relatively similar. It's a little bit more expanded upon than the initial one, and all patients really that are enrolled in this it's the intention to treat the deformity at the time of the original surgery. So those are the two main distinctions we wanted to look at: our utilization of three-column osteotomies, as well as our outcomes and how we're doing in a more complex population and with more contemporary ideologies and techniques.
Yeah, I would imagine this paper is somewhat a response to some of the earlier ISSG work with respect to highlighting an increase in utilization of three-column osteotomies maybe about 10 years ago. I don't know if you were involved with that work, but I'm sure familiar with it. Do you feel that this paper was kind of the natural continuation of that line of work?
Yeah, you hit the nail on the head, Byron. Exactly, your line of thought is what we were thinking at the time of the hypothesis generation. So there was actually what we now consider to be overutilization of three-column osteotomies, somewhat as a excitement in our response to the acknowledgement of sagittal plane deformities and the disability that they generate, and our ability to correct them operatively, where almost as a knee-jerk response, three-column osteotomy realignment for anyone with some semblance of a 20 to 30 degree lumbopelvic mismatch. And certainly these, as we will get into in this study, even in contemporary times, amongst surgeons who do this really as a career, these are not to be taken lightly. There's serious consequences upon the recovery course, as well as the complication profile. And I think more of a selective analysis of the utilization of three-column osteotomies is warranted in reaction to the previous overutilization, perhaps.
Great. And before we kind of get into your summary of the paper, I would like to maybe hear a little bit more about some of the other authors on this project, particularly the first author. I think as somebody who, involves a lot of trainees and younger surgeons on research like this in our lab, I'd love to hear a little bit more about kind of some of the younger authors and give them some credit for this work as well.
Yeah, I mean, we have a similar setup, maybe on a smaller scale. I'm very familiar with your lab and the excellent work you guys have been doing, and probably the most prolific lab in the country. So congrats on that. Tyler was one of my research team several years ago. During this study's performance, and he was in the process of applying to orthopedic surgery residency, and he was just an absolute star. And he was with us only for a year. He had a tremendous year, and countless publications, presentations, and he continues to work with us in some capacity. He's matriculated, and he's now at the University of Texas, San Antonio, as an orthopedic surgery resident, and we're hoping he goes into spine. I think he may have also proclivities to some other subspecialties, but that remains to be seen.
Awesome. Great to hear. Well, with that, why don't you dive into kind of some of the meat of the paper and give us maybe overall kind of summary of the work that you all have done.
Yeah, certainly. So this was, as mentioned, this was really a glimpse of the early outcomes of the immature database at the time, where we didn't have full 2-year follow-up. But this is our initial look at patients who had undergone three-column osteotomies. The population that was derived was from the time period of 2018 to 2022, and as stated, all patients were incorporated into this ISSG complex database. And the way, we hypothesized that essentially there would be distinctions in the recovery patterns, as well as the realignment, both in construct and out of construct profiles of these patients, and most notably the outcomes and the perioperative complication rates. Some of the sub-analyses we wanted to do is utilization, which patients really these were being utilized, levels, as well as more contemporary and sophisticated realignment principles, such as proportional realignment, which were being introduced along the time that this project was performed, which were novel to previous similar works with older data sets. For the purposes of this study, we defined complex adult spinal deformity really as was the initial IRB protocol, that of a mismatch greater than 25 degrees, a T1PA greater than 30, and SPA greater than 15. Thoracic scoliosis curvature needed to be greater than 70, or thoracolumbar scoliosis greater than 50, and global coronal malalignment greater than 7 centimeters. There are also some procedural inclusions, so patients could be included in this data set just based on the performance of a 3-column osteotomy and more than 12 levels being fused. So there was the mixing of the criteria, but basically all patients had at least one of those radiographic criteria to be included. Our outcomes, many of which are standard, in our field in terms of hospitalization, length of stay, hospitalization within the ICU or regular floor, perioperative and postoperative medical, mechanical complications, reoperations, and patient-related outcomes were reported based on traditional PROMs, the Oswestry Disability Index, the SRS-22, NRS, and PROMIS. We have utilized PROMIS CADS model, but that was not utilized for the purpose of this because the data was just too mature at the time. For those of you who are not aware, basically PROMIS has more traditional metrics in several domains, and then there's an AI-based response which tries to limit the questions, but also tries to steer the question along the line of of certain subpopulation clusters and outcome clusters, but that was not utilized for the purpose of this study. One other notable difference was we used the Veterans RAND 12, and that was for several reasons why we decided to use that in our data set. One was just ease of use. It's obviously shorter than the SF-36. It's also very easily translated into economic data for our outcomes-based data, into several other forms that have been validated. And the most probably practical reason was that it didn't require licensure. So, it was free of charge for our patients to use and our sites to use. We looked at patients, with regards to rigidity, and the rigidity is always a topic of contention, how it's defined. We use traditional definitions based on standing and supine definitions with less than 33% change in L1, S1 lordosis as being the definition of a rigid deformity. We didn't isolate the population to rigid deformities. We wanted to include both to look at some of these 3-column osteotomies were performed in non-rigid deformities. Maybe there was a focal rigidity, or the surgeon thought there was a particular need for that at the time of their surgical planning. Overall, about 249 complex ASD patients met eligibility for the general inclusion. Some of the sub-analyses had slightly lower numbers. 3-column osteotomies were performed in about 21% of patients in the population. And there were some notable differences from a demographic perspective. 3-column osteotomies were generally older by about 5 years, 65 relative to 60, more likely to present as a revision and a more severe deformity. From an outcomes perspective, there were also distinctions technically at the time of surgery. 3-column osteotomies, this was around the time when multiple rods were becoming popularized, particularly at the 3-column osteotomy site. So they were much more likely, I believe it was 4 times, to have secondary rods, either accessory or satellite base, at the 3-column osteotomy. There was better correction noted that was incremental. So it wasn't just if you did a three-column osteotomy, you universally had better correction, but you had better segmental, regional, and overall correction based on the grade of the osteotomy. So a grade 3 SRS Schwab classification had less correction than a grade 4, and so on and so forth within that osteotomy classification. We did notice differences in the outcomes for complications, as would be anticipated. Three-column osteotomy patients had 4 times greater risk of massive blood loss, and we defined it. And again, this is a controversial topic in our field, as Byron knows very well. But we defined it as greater than 3.5 liters, and based on previous literature. Also, three-column osteotomy patients had greater length of stay, higher rate of SICU admission, either SICU or neurosurgical ICU, and more wound and surgery complications. Neurologic complications were significantly higher in three-column osteotomy patients, particularly when performed below the L3 level. And this has actually fostered several side projects as a result of that finding, some of which include the performance of complete superior and inferior resections at the lumbar levels, particularly distally, to minimize neurologic impingement with these dramatic corrections. In terms of PROMs, there was similar improvement in both groups. We did compare primary three-column osteotomies versus revision cases, and I think maybe a little bit underpowered, but we did not notice any significant differences there. Our cost analysis was a virtual cost analysis using Medicare DRG allowables projected up to 2-year cost, and it tended towards a higher cost in the three-column osteotomy group. And the drivers of that were not just the initial impact of the surgical, ICU stay and length of stay, but also the complications and the reoperations also drove that as well. There was a higher opioid usage among the three-column osteotomy patients, which we thought was interesting, and that may be related to the revision status being slightly higher. And three-column osteotomy patients had better rates of improvement from the preoperative state, which we thought was kind of recognition that these were being done, even though they were higher risk cases, being acknowledged, they were being done in an appropriate indication, because the end result, which arguably, what really matters is the clinical outcome. These patients really had a dramatic improvement, and a higher percentage of three-column osteotomy patients actually stated on their questionnaires that they would have the surgery performed again if they were given the choice. So I'd say those are the main findings, within our study, and I certainly look forward to hearing your questions to dive deeper, Byron.
Yeah, that's great. So I think if you had to summarize your findings in a single punchline, as much as I hate to do that, three-column osteotomy is powerful, but it comes at a price, both literally and figuratively in this case. I think that it's noteworthy that amongst a group of world-renowned surgeons, all with over 10 years experience, I believe, at the time of this publication, treating the most complicated adult spinal deformity patients, the utilization of three-column osteotomies is around 20%. What's your take on this at a practical level and personal experience in your own practice? Is this about the right utilization rate, you think, when you take a group of surgeons like this?
I think like many other things in our field, it really depends on the type of patient population you're seeing. And I think that number is difficult to hang your head on, because more historical, in our group and other groups have about a utilization rate of about 17%. And then there was some more, contemporary literature around the same time that showed that three-column osteotomies were being performed to a lesser extent due to multiple interbodies being performed, new techniques such as laterals, and really the desire to achieve a more harmonious realignment as opposed to a focal realignment. And so, but then that's coupled with the new data set having more complex patients. So I think if we had the same complexity, we would see a diminished utilization rate. But amongst patients that meet this criteria, I think there is some acknowledgement based on our results that this is probably somewhere around where it should be. In these surgeons' skill sets and with contemporary techniques, we hope we're improving and our indications and our planning and our prevention of junctional failures and other things. Those are certainly the major topics of research in our field. But I think at the time of publication, within this population, 20% was pretty much a good call within our practices.
Great. I also believe this paper provides us with some real world messages that we can use in our daily practices, most notably regarding complication rates and outcomes. In particular, the fact that somewhere between 20 and 30% of patients undergoing a 3-column osteotomy will experience a neurologic complication, which can be one of the most difficult roads to walk a patient down. What are your sort of take-home messages, and how can we relate this paper to daily clinical practice and how we counsel our patients?
Yeah, I think a lot of it is exactly what you stated, is counseling. Fortunately, many of these complications are, I don't want to say part of the recovery, but perhaps a better word is transient. They, if there's an L3, 3-column osteotomy, it's not uncommon due to stretch-related issues, more than likely to have quadriceps weakness. And if you're more distal, has a different set of distribution of neurologic deficiencies post-operatively. We found that in other studies that around 17% were persistent, looking at 1 to 2 year outcomes. So, I think the take-home message there is that it's real. It's definitely something that many patients experience post-operatively. Fortunately, most of it tends to be transient, but it's another factor that we consider, in the need to perform a 3-column osteotomy, whether or not it's indicated. And that's probably one of the reasons why we're doing less of them in primary cases, because there's lower neurologic complication profiles in interbody techniques and, again, more harmonious corrections. We've also changed some of the, I think we've gotten a little bit better at minimizing these. And a lot of these are reflected in minor complications. So if you had, 1 grade weakness in a myotome, that was considered a neurologic complication, but arguably, one of the main things we're trying to avoid in 3-column osteotomies, especially at the cord level, is catastrophic injuries, spinal cord related. And those rates have gotten better in our series. So I think, that's something that's notable. But I think the nerve roots have really hovered around and lingered as a problem with the lower 3-column osteotomies. And that's one of the reasons why a lot of us are doing really complete resections in the lower lumbar spine, even at levels the 3-column osteotomy is not being performed, to prevent secondary compression in the foramen.
Great, and I'm sure one follow-up study you are probably looking at is the sort of, obviously it's important to know these neurologic outcomes are at 6 weeks after surgery in this paper.
Right.
And what's the prognosis, relative for a quadriceps deficit versus a foot drop? I know I've had a lot of kind of back and forth conversations with people. Mike Kelly comes to mind as somebody who has suggested to me that it's much easier clinically to deal with a foot drop than a quad drop. But it'd be very interesting, I think, in this data set to look long term at the prognosis, and I'm sure that we look forward to that follow up. One thing I noticed was there's a pretty wide confidence interval, somewhat expected with respect to blood loss. Obviously, this is a a variable that's notoriously difficult to accurately measure. But I wondered if you could comment on the utilization of anti-thrombolytic agents like TXA amongst your group, and is there standardization in this data set, or is there still significant variability?
Yeah, great question. So I think the TXA question is a very poignant one, and to your point, there really was no standardization at the time. This when we started this data set, there were still it was still anxiety provoking, I think, at many institutions to use this, in certain patient populations at the doses that we were using them at. So it was a bit of a learning curve where institutions became more comfortable with it. We started to see our initial results, and the overall utilization was pretty broad spectrum. I think the most common utilization within the group, if you look at new enrollments, is around the range of 50 and 5. So 50 mg per kg bolus, and then 5 mg per kg per hour continuous infusion. And I think that's probably the most commonly utilized dose in our current data set, although it's not published data. That's just looking at the data set, not controlling for other factors such as size of the surgery. We think there's been numerous publications by many groups showing the efficacy and the relatively safe profile of TXA. And it's a medication that's been used in multiple subspecialties, not just spine surgery. So we think that does play a role. There's other factors too. There's there's the way you perform your surgery. There's interbodies being performed in lesser invasive techniques with prone laterals and other things like that, in which we have several in our series as well. I think even just becoming a better surgeon, knowing what to expose first, what portion of the procedure to do first, how to minimize blood loss. I think that comes with experience. So I wouldn't attribute the improvements in EBL to entirely the TXA. I think the broad variation is really reflective of ASD surgery. There's so many different types of surgeries, whether it's revision, 3-column osteotomy, 18-level fusions, 12-level fusions. So there's always going to be some variety, and I think it's also very difficult to characterize. We went at my previous institution. We went to a semi-quantified technique of measuring sponges and residuals of what was not collected in the container. But I will say even that was broadly variable based on staff. So I think EBL is just something that's tough to measure, and it really needs to be based on probably body mass and invasiveness of the surgery, IV fluids received, starting hematocrit, and it's beyond the scope of this series.
I totally agree. I think it'd be beneficial if you could talk our audience through your protocols for level selection of PSO, and maybe what we can take away from this work. There were some pretty nuanced findings in your paper about what level and what grade provided the best correction in specific parameters. Are there any take-home messages you'd like to share with the SRS podcast listeners?
Yeah, I think thanks for bringing that up, Byron. I think that was one of the things we were looking to achieve with this. It's a lot to fit into one manuscript, but really the differences in where the osteotomy is performed and the starting malalignment and what you achieve, I think are some of the nuances that we can take from this when we work on our surgical planning. I think it's really standard in our field at this point to think about our surgeries prior to performing them and to really plan these out well. I will acknowledge there are many ideologies from a realignment perspective. As you mentioned, some of the people you mentioned previously on this webinar, have distinct ideologies. ranging from disparity in T4 and L1 pelvic angles. T1 pelvic angles is kind of a global perspective of of the relationship of the spine to the pelvis. And then, our original kind of really game-changing findings that have been modified over the years, with the SRS criteria being modified for age parameters and later, for frailty parameters and then in the last 10 years, our understanding of proportional alignment, how the pelvic incidence really modifies our targets. So, I would say that, this data in this series is really kind of reflective of multiple ideologies. So not one distinction, but we're thinking about these concepts more, and I think that's what makes the difference. Some of the interesting findings with regards to the PSO, or the three-column osteotomy performance is that, you can't just look at a global parameter. So if you're just looking at a global parameter, then your upper three-column osteotomies influence TPA the most. But that doesn't capture the entirety of the proportional alignment within the lumbar spine. So you have to have some more of a patient specific and pelvic specific perspective when looking at these. So I think some of those concepts that I take into account are the amount of lordosis at the base of the spine relative to the PI. So many of us have a relatively quick and easy rule, of around 35 degrees. But I think more importantly, the proportion based on the PI of what should be allowable in the upper lumbar spine relative to the lower, and that's what influences the proportion more often than the mismatch. I think influences my determination of whether or not the patient requires a three-column osteotomy in my current practice. I think it's not picked up in this series, but they're also very powerful coronal realignment tools, and I think that's some area for further work. I think a lot of us have moved to segmental realignment, and so even not just L4-S1, but the mounted L5-S1 and L4-5, and reproduction of of what we would consider from a functional perspective, normative values, within the segment, I think is the contemporary way I plan for these surgeries. And generally, I'm not doing a three-column osteotomy on someone unless it's a rigid deformity, or unless it's that's proportionally malaligned that I can't correct with other techniques.
Great. So what's next following this work? What is your group going to do as a next step of this project?
Well, I think one of the initial intents is really to, as you know, and as many of us know, 6 week outcomes and 1 year and 2 year outcomes are not what adult spinal deformity is about. When you do an adult spinal deformity, it really has to last for that effort, that complication profile, and that expense of a procedure to be valuable. And then with recent, NIH-funded data coming out with 40% rates of rod fractures at around 5 years, and reoperation rates, being so high, I think those are the real things that, it's not a matter of do we realign the patient properly at 1 or 2 years. It's a matter of, does the operation prevent another operation at 5 years, so that patient can have a value-based procedure, that's from a societal perspective is sustainable. So I think those are the bigger pictures, really the longer outcomes of which subpopulations benefit most from three-column osteotomies. And it's really two different questions. There's the getting them through the phase of the initial surgery, because not everyone can tolerate a three-column osteotomy, and that's why we minimize utilization. And then making sure that doesn't translate into an operation that looks great for 6 months to a year, but then falls apart. And that was one of the initial problems we were having in spinal deformity surgery, where we were overcorrecting everyone. And we really paid the price for that from a junctional failure, mechanical complication profile. So really, the longer term outcomes are the main things we want to look at, and is the reason why we're maintaining and spending so much effort on these data sets.
Great. Well, it's been an honor having you as a guest on the podcast. This is really important work. We look forward to the subsequent studies coming out of this data set, and are greatly appreciative of your time tonight and sharing your expertise with our audience.
It's always an honor to talk to you, and I'd like to thank the Spine Deformity Journal and the SRS for sponsoring this, and it was a really, really real pleasure and honor on my end as well, Byron. Thank you for the invitation.